Okay, so I have 4 cases. This is my first one. And I do have the chat up, but feel free to speak up or chat in. What do you guys think about this? I'll just stop here.
The pancreas, something happening anterior to the pancreas.
Good. I think, yeah, there was pancreatitis. Let's ignore the pancreas for now. What about this area? This slice. Swachanda is saying RVT, so renal vein thrombosis. Excellent thought. The renal vein, though, looked pretty good. But I think he's noticing that this kidney looks like it's very dark compared to this one. We're in the delayed phase.
And even the artery, do we see the renal artery well?
Great. Another great thought. I was thinking the same thing, that this kidney was completely infarcted and that this may be the rim sign of preserved renal cortical enhancement. The renal artery, though, is right there. And it's also looking grossly patent. Rupa is asking if it's calcified. I can't really tell because I'm bad with, oh, you mean the whole kidney? Is the whole kidney calcified? Excellent thought. That's not what's going on here. But you could see like a putty kidney and tuberculosis. That could be really T2 dark. I'll show you the T2. This is what it looked like on T2. They looked pretty symmetric. It didn't look really dark like maybe a really calcified kidney would look. It's hemosiderin, so I'll show you the in and outs. Here's the in phase, doesn't look dark. Out of phase, they're pretty symmetric. I'm glad I wasn't the only one stumped by this case. Yes, Rupa, it's an artifact. Anyone know the artifact? Okay, so this is called fat swapping. This kidney is totally normal, and it's an artifact called fat swapping, and it happens when you're using the Dixon method, and there's some kind of inhomogeneity in the field. I don't know what's causing it here, if it's related to the fact that the patient's like touching the bore here. My friend Mary Ellen brought up like, oh, could it be gas like in the colon going by, because that can create field inhomogeneity. But because of that, it'll cause fat and water to swap. So instead of the water in the kidney being seen here, it's interpreting this as fat and saturating it out. You can confirm this by going on all the other sequences. The kidney looks totally normal. So it's not infarcted, it's like completely normal, and it's an MRI artifact called fat swapping. Any other comments? Christine is asking, why is it only affecting the left kidney? Yes, I agree. I was shocked by this. I was like, why is it only affecting the kidney versus all the other things? If you look on Radiopedia, they actually show an example just like this. Apparently, it can affect just one organ. It doesn't even need to affect the entire field area. Do you know why it only affects that one organ?
Often regional, and it happens to be in that area.
Yeah, so it can be regional. So it's just something to be aware of. On all the other sequences, luckily in this case, the kidney looked completely normal. And so then we were like mystified, like, why did it just infarct between the venous and the delayed phase? And then we learned about this fat swapping artifact. So yeah, and I can show you, this is the Radiopedia entry. It's not extensive, but you can see here, they have an example that looks similar. In theirs, actually, it's like half of the abdomen it happened, but basically they say there's like incorrectly determining whether there's fat or water, and a solid organ appears black on suppressed images. Okay. Move on to my next case. So this was a patient who was undergoing, so they had multiple fibroids. You can see they've got a lot of enhancing fibroids, including actually a intracavitary fibroid, as well as a pedunculated enhancing fibroid. So we've got extensive fibroid uterus. A lot of them were enhancing. This patient ended up going for UFI. So these are some images from their UFI. And they basically embolized the uterine artery bilaterally. On our MRI, we always look to see if there's any hypertrophied ovarian arteries as well, and we didn't see that, gonadal veins or gonadal arteries, but that is something I want to mention in coming up. Anyway, this is the post-UFI imaging. The patient came back with abdominal pain and fever. So what do you guys think about the post-UFI CT?
There's air bubbles. I mean, I guess theoretically you can be infected, but yeah. Rupa said it's expected from necrosis. Oh, is there like a syndrome like post-UFI, like for example, like the thrombolysis syndrome where they get all these symptoms?
I don't know if I know there's like post-embolization syndrome when you embolize like in the liver and stuff, and basically you have like flu-like symptoms. But yeah, so the question is like, is this gas normal? Is this expected? Is this a sign of infection? And as Rupa is saying, this is kind of expected from necrosis. I've even seen quite a lot of gas within the uterus. Oh, that was Anu. I don't know if you saw her, but anyway, so you can get quite a lot of gas and it can be expected and normal. And in this case, the patient had fevers. And so we had a big debate about this, like, how can we tell if it's infected or not infected and whatever. And we basically essentially decided we can't really tell, but that gas is really common post-UFI. It's usually a sign of necrosis. It is not, you don't necessarily jump to infection. They ended up treating this patient conservatively and giving her IV antibiotics, and her pain got better, and she did fine. One other interesting thing is that you can see this fibroid here is still vascularized. So even though I said that we didn't see a lot of like hypertrophied ovarian arteries, our theory is that this pedunculated one wasn't fed by the uterine artery like the rest of them. And so if you really wanted to get this one as well, you probably should have gone in the ovarian artery. You always have a risk then of causing ovarian failure, like if you necrose the ovary. But this pedunculated one is probably not causing her symptoms. So they decided to just leave that one alone.
I just Googled, and there is a post-UFI syndrome too. And it says
cool.
on Google, it says post-embolization syndrome characterized by low-grade fever, pain, fatigue, nausea, and vomiting. And it's after a UFI, uterine artery embolization, and the symptoms peak at 48 hours after the procedure and resolve on their own within a week.
Cool. Let me just look at the date and see. Oops. Let's see what. This was, wait a second. She started having symptoms a month after, or she came in a month after. So it was a little cryptic, but the gas actually stayed the same after for like a couple of weeks. So we really thought it was just from the necrosis. Okay, this is my next case. This is a male patient with a large, you can see retroperitoneal mass. It's 35.
Can you show me the left kidney?
Some kind of a germ cell tumor,
like a liposarcoma,
teratoma, malignant teratoma, or something like that.
So here's the left kidney. So I'll go one by one. So Nellie, here's the left kidney. And I can see you're like wondering, is it coming from the kidney? It's squishing the kidney. It's really hard to say, like, is this a claw? Like, I don't know, but it seems mostly centered outside the kidney. And then somebody brought up a liposarcoma. That was actually something I was thinking immediately, like as soon as I saw like a huge fat-containing retroperitoneal tumor, but it looked kind of weird to me. I was like, oh, what kind of subtype of liposarcoma is this? Because like it has all these, you know, is it a myxoid with well-differentiated components? And but it looks a little weird. And then who was it, Kedar, who said germ cell tumor?
Tarun.
Oh, Tarun, sorry, I always mix you guys up. But yes, so that's a great thought. And then Rupa's asking about the left testicle. So I was thinking something similar too. And I was like, oh, they still have their spermatic cord. They probably didn't have an orchiectomy. But as you see, actually, as you go down, it disappears, and they have had an orchiectomy. And this patient does have a history of a testicular germ cell tumor. And this was their huge nodal metastasis. So just a quick refresher about germ cell tumors. So germ cell tumors are the most common testicular tumor. They can be seminomatous or non-seminomatous. And when it's huge like this, it's usually non-seminomatous germ cell tumor. They tend to affect younger patients, and they're often like a mix. And this is like for boards, they always ask like, okay, they can be a mix of like yolk cell, choriocarcinoma, embryonal cell carcinoma. Yolk cell is the one that will elevate your, not your HCG, your AFP. Yolk cell will elevate your AFP, and then choreo will elevate your beta HCG. Oh, yolk sac. What did I say?
Yolk sac. Yeah.
Okay, yolk sac will elevate your AFP, and choreo will elevate your HCG. And if they're markedly elevated, that's a poor prognosis. And then there's also like, you can have a teratomatous component. And I think this one ended up being a combination of, like, it's a mixed one. So it had teratoma, yolk cell, and embryonal cell. And I think the fatty components are from the teratoma component. When it's this big, it's actually growing pretty rapidly. So they're just treating it with chemo. They're not even trying to resect this. You can see it's encasing the aorta here. So even if this was a liposarcoma, this would be really difficult to resect because you really need to get a margin on everything, and you can't really, get that on the aorta. They have done aortic, basically where they replace your aorta, like resect, remove your aorta with the tumor and replace it, but that's a lot more complicated. So anyway, this was just a huge non-seminomatous germ cell tumor metastasis.
Wow.
Yeah. Okay, and then this is my last case. What do you guys think about this one? This patient has a history of multiple of urethral strictures with multiple dilations. And this is the sag, and then this is the coronal. So someone's asking about TB. Good thought. Who else?
It's Steve. Based on what you said, you think about lesions caused by injury or chronic inflammation, but it's hard to get off when you see something that looks mass-like, something neoplastic too.
Yeah, exactly. And so this patient actually came to us with a known diagnosis of squamous cell carcinoma, and we were basically doing the staging. And so this just kind of shows you how nicely MRI can stage penile cancers. So for example, like they were able to go up to through the urethra and sample the tumor and get the diagnosis, but they have no idea how extensive it is. And that's going to change the management. If it was just a small lesion of just the urethra, they could even do a urethrectomy or a partial penectomy. But you can see this lesion actually it measured up to like 5 centimeters. It's going pretty proximally, involving a lot of the bulbar urethra. So this would necessitate a total penectomy. And like Steve said, the risk factors are if you have had like chronic inflammation, people who have had chronic strictures, dilations, much higher risk. Penile cancers tend to be squamous cell carcinomas, either extending from the skin or from the urethra, especially the more distal you go, it's more squamous cell. And then the more proximal you go, like if you're in the prostatic urethra, then you can get urothelial cancers. And this is a nice view of the anatomy. So here are the corpus spongiosa, and this is the corpus cavernosa, and this is the spongiosum. And then this T2 dark line here is the tunica albuginea. And part of their staging is they want to see if it's invading the tunica and also extending beyond the penis itself. So you can see that this one is centered in the spongiosum, but it's definitely invading the cavernosa, and it's also disrupting and going through that tunica albuginea. It has necrotic components. It's spreading along the cavernosa here. So that is extensive local extension, and that would necessitate also a total penectomy. And just to review anatomy for one sec. So we've got our spongiosum, which is Like this is kind of like the face. So the two eyes are the cavernosa. Those are like the blood-filled chambers. And then this is the spongiosum that has the urethra going through it. And then this white layer here is the tunica albuginea. Okay, that's it for me. It looks like Christine has a case.
Hey, yeah, I can show a case. So this is a 45-year-old woman who came into the ED with right lower quadrant pain. And initially when we looked at this, we thought that obviously there's a lot of inflammation around the appendix, which is, somewhat thickened. And then there is this like what looks like maybe a collection in the, in that area as well. So at that point, we had given the differential of possibly perforated appendicitis versus, could it be periappendiceal inflammation from like PID or something like that? And so this patient was started on antibiotics and like I think this is a month after that initial CT already. So she comes back in for her follow-up CT. And at that point, the inflammation is definitely better. The appendix is not as thickened. You can see that it's right here. However, there's still like this fluid density structure right there. So does anybody want to give a guess for this?
I would add mucocele.
Yeah, that's great. Yeah, so they did end up taking the patient to surgery, and they found a low-grade appendiceal mucinous neoplasm, which has penetrated the serosa. So just a really nice case of that.
So was the inflammation secondary to that, or was there a concurrent inflammation going on superimposed on the mucocele?
Right. I think it's hard to tell. The fact that like they have found the tumor to have like extended through the serosa makes me think that, there's like a chance that it might have spread. But it could also be that there's secondary infection on top of all that too. So for follow-up, the surgeons were planning to do a repeat laparoscopy in 3 months to look for recurrence because they thought that, if there was like microscopic disease, it might be hard to see on imaging.
But I guess maybe they were 3 months in there.
We have a couple of questions, Christine. Well, one was this, it's kind of cool that like you can see part of the proximal appendix. So it's almost like half the appendix was normal and then the other half was, because you see like another part of the appendix there, right?
Yeah, like right here, right?
Yeah. So it's like
And then
half of it was normal and then the distal part had the mucocele.
Right.
That's pretty
like
cool.
This part. Yeah.
Then we noticed that the left ureter was also like dilated and thickened. We were just wondering if like maybe that some of that fluid in the pelvis was the ruptured mucinous stuff and it's now causing like a little bit of hydro of the left kidney.
Yeah. Let me see. I think so. I mean, I don't. Oh, and then I guess they also have a stone. Yeah, I forgot about that. There's just some mild hydro from that stone too, it looks like.
Nelly, it's Hickham's dictum.
Yeah, tell me about it.
And then my other comment was
Not
that
again, please.
my other comment is that if we bring up mucocele, they usually will go and do they'll do a more extended. So it's good to bring, if you're thinking about it at all, you should bring it up because they'll do, instead of just doing a laparoscopic appendectomy, they'll usually do like an extended partial like hemicolectomy so that they can get margins.
Mm-hmm.
And then Mary Ellen and I were just wondering like if they then saw like if they thought it was going to be mucocele, would they do like kind of like the peritoneal stripping and stuff like in there while if they saw like gelatinous stuff in the abdomen, like if it looked perforated,
Right.
And I don't know the answer if like they wait to do the HIPEC, or sometimes they do it right away, or?
Yeah, I'm not sure either. But that's a great question. I think for now they're going to do surgical follow-up. So they may decide when they come in 3 months to do that.
Cool, yeah. Because especially if it wasn't obvious, then maybe just wait and then see if it develops, and then at that point do a HIPEC.
Mm-hmm.
Cool, thank you. We actually recently had a couple of cases too, where it's always like the appendix versus PID. And I would say statistically, like the appendix is always going to be more the culprit and stuff. But yeah, this was a cool one. Does
That's
anyone else?
That's when you get the fight between the services. Who's going to take the patient?
Yes.
Then you have those moments as a radiologist where you see the horrible, what it looks like horrible inflammation or cancer. You're like, I feel awful saying that this might be cancer, but I feel like I have to say this might be cancer, and it turns out to be cancer, you know, in a young person.
Yeah, I think if there's any like possibility that you see an appendiceal cancer or a mucocele, you should bring it up, because it'll change their management.
Yeah.
Better to be more aggressive the first time around. Does anyone else have cases?
I'm in the middle of a clinical workday and somebody could walk in on me. Otherwise, I just did a follow-up that was kind of cool. I don't know if I can show it. Maybe I will. I'll try to.
Okay.
Hang on, let me get rid of the, I gotta get rid of the, on the CT, it's the typical, you know, pancreatic cystic lesion, 7 millimeters. And so a recommendation based on the incidentals of, you know, can be an IPMN, things to look for, ducts not dilated next to it. So looks like it would be side branch if it's one of those. And so the patient indeed had a follow-up MRI. So I'm going to put that up next. This was how long, much longer? It was about 7 months later. And sure enough, here's the cystic pancreatic lesion, which doesn't look too interesting and is going to be something to follow. But on this one, there was a splenic lesion. This is T2. Actually, well, here's T2 also. This is T2 non-fat sat. Kind of solid appearing, measures about 18 millimeters. Going back to the CT, which I'll put down below, maybe a hint of it on this image. I don't know if you can appreciate that. But you know, MRI shows things better, so there's a thing there. There's also something in the splenic hilum. The spleen's kind of big, measures 15 in this plane, in the other plane. Coronal, not quite as tall, but there's the splenic lesion again. So if it was 15, and then this is like maybe about 11, it probably averages out to mildly enlarged spleen. And then this thing. So, you know, splenic lesions are troublesome, aren't they? Because most of the time they're benign, nothing. We don't know what we're looking at. The worst thing they could be is like, maybe somebody can offer, but I'll just say angiosarcomas or lymphomas are the most common splenic cancers that I'm aware of. Could this be lymphoma? Yeah, I guess it could. So some time went by. It was described as something, you know, indeterminate, something to follow for next time. The next time was indeed the MRI follow-up, which now looks like this on the top. So I'm going to put the old MRI, and now these are separated by about 13 months. So nobody was too excited about this. So 13 months went by, and now there's quite a few splenic lesions, right? There's like this one, maybe it's now exophytic and growing. there's some additional lesions that don't seem to have been there before. The thing in the splenic hilum that's kind of splenic hilum / pancreas tail is larger. And there's some lymph nodes. So already talked about the differential for splenic lesions. I was the one who read this one. These other ones were before me by other folks, but I did talk about, angiosarcoma, and I'll show you the contrasted images, angiosarcoma and lymphoma for these liver lesions. Kind of just, I didn't like the looks of it. Obviously, they show up, some of them new and then some of them larger compared to this prior. So I was worried about malignancy. And so subsequent to this, and I can show you, kind of try to avoid doing biopsies of the spleen very much, but I'm not going to show the ultrasound images of the splenic biopsy because I think it's got identifiers on there, but that's what the patient had. Then there was a CT after that. I think there's a little bit of hemorrhaging going on. Maybe I can show that. This is the CT after the splenic biopsy with a little bit of minimal, honestly, hemorrhage here. Which is why you kind of trying to, I don't do actually interventions. We have an interventional service. They did the splenic biopsy. I don't know really which one they went after, but more superficial, maybe with a little bit of intervening parenchyma to tamponade some hemorrhage, but it still hemorrhaged a little bit. And then the diagnosis was indeed lymphoma, diffuse large B-cell lymphoma. Subsequent to that, a PET CT, which basically shows that the disease of the pancreas tail was part of this. Then there's lots of splenic lesions, not much in the way of adenopathy in terms of size, but there are some positive things. There's actually a lung lesion that was picked up on a staging CT afterwards. Also, thoracic nodes like subcarinal, axillary, supraclavicular, and then treated did well. Looks like the next PET follow-up was this one here, and a substantial improvement in disease. So it's kind of like I mark cases for follow-up, and especially when I hit that MRI, that things look bad, and I wasn't sure if I was looking at lymphoma, angiosarcoma, or metastatic disease that would be weird to the spleen from something maybe in the pancreas. Turns out it was lymphoma all along.
Great case. It's so nice to see like the beginning to the end. Satisfying.
It is satisfying. I agree.
And the IPMN was unrelated, right? There wasn't
the IPMN has sort of been along for the ride the whole time, and it was incidental. But when we have these patients under surveillance, whether it's IPN or something else, they crop up with incidental cancers, and you're lucky to catch them as early as you are. My father's actually a case in point where he was under surveillance for lymphoma, and there was a change in the caliber of his bile duct, and it was pursued, because I'm heavily involved, he was pursued very quickly with endoscopic sonography and biopsy. They plated the cells right in front of me. It was adenocarcinoma. He had a Whipple. That was almost 10 years ago, and he's survived a cancer that wouldn't have been detected otherwise, but for the surveillance for his lymphoma, which he was cured of already. So we can do this.
Are you making the case that we should all get screening full body exams?
No. No, but I'm just saying, there's some value in it, obviously. We do all this imaging, you think you're just wasting time chasing pancreatic cystic lesions, but other important stuff can crop up too.
Yeah, there's an NIH RFA that's out there looking for oncologic screening on imaging done for other reasons right now using AI.
Cool. I was actually only half joking about the screening full body thing, because I was thinking about all Perry Pickard's work with all the like sarcopenia and stuff, and I was like, I'll get my full body screen and I'll check out my sarcopenia, and like maybe
It's
that'll
funny.
motivate me to get on the Peloton.
It's funny you should mention that, because we are probably here going to participate in Perry's Oscar trial, which stands for opportunistic screening for, I can't remember what the acronym is completely, but and it's because he pitched this at, I think, RSNA or the last SAR. He was looking for people with a broader demographic than Madison, Wisconsin, and we have a high Hispanic and Native American population. So I kind of talked to my people and said, maybe we want to help participate in this to boost some of the numbers for Perry. And anyway, it looks like we're moving in that direction.
Nice, cool. Anyone else have cases? Or should we end early? I hope you guys had a good long weekend, and we will see you next week.
Thanks all.
Bye.
Thanks. Good to talk to y'all, as always.